Hi everyone, welcome to another careers talk at Mind the Bleep. Tonight we've got Indra who is going to be doing a talk on radiology. He's an ST1 and he's about to start his ST2 post, so enjoy. And if you've got any questions, make sure you put them in the chat and we'll ask them at the end. And I'll put the feedback link in at the end as well so you can get your certificates of attendance. So do you want to take it away, Indra?
Cool. Yeah, so thanks, Frankie, for the introduction. So, as you mentioned, my name's Indra. I'm one of the radiology trainees based in Oxford. So, hopefully, over the next kind of 45 minutes or so, we can touch on what a career in radiology is like. I'll talk a little bit about applying and the portfolio towards the end as well. And again, if you pop any questions in the chat, and at the end, we can have a discussion. Frankie, if there are any like really burning questions, then again, feel free to interrupt. That's cool as well. If they just slot in nicely. So yeah, I thought I'd start just by mentioning a little bit about my journey. I didn't used to when I gave these talks, but a lot of people seem to want to hear about that, so I'm happy to share that. So I went to med school in London, and for a long time I wasn't sure what I wanted to do. I know early on everyone, or at least it seemed like lots of people knew what they wanted to do, and I had no idea. But towards the kind of end of clinical med school, I thought about maybe surgery or maybe cardiology, something that had some practical stuff. But again, these were just kind of fleeting thoughts. And I luckily got the opportunity to do a student selected component in radiology as one of our options in final year. So I picked that just to kind of find out what it was about. And I mean, I guess my life transformed from there because it was such a good experience. So, I found really good mentors there who showed me what a career in radiology is like. I got involved in a research project during that time as well. So got a little bit of a taste for, the academic side of radiology. And yeah, it made me really interested to explore the career a bit further. So I then organised an elective. So I did 2 electives at the end of final year, one in surgery, and I did that in New York, and I did one in interventional radiology because during my radiology SSC, I thought that was really cool, and my mentor was an IR person, so I did both of those electives, and both are really, really good. But I think I enjoyed the IR one just a little bit more. I mean, both are really, really hands-on, but I just loved the variety that I saw. So I got to do loads of stuff. Like, for example, by the end of the 4-week elective, they let me do a biopsy by myself, which was really cool. So yeah, I just got loads of hands-on experience towards the end of med school. So I think after those electives, really it was just going to be either of those two. And during my foundation years, I had a lot of contact with, I did quite a few surgical jobs, but also I also volunteered to go to radiology a lot. So I got some contact with the radiology department in F1 and F2. And I think that just further solidified my desire to do radiology, essentially. I also got involved with the BSIR, so that's the British Society of Interventional Radiology. So every year they have a foundation representative election, so I applied for that. And through meeting that committee and, like meeting some good mentors, we set up some more junior things for IR because, it's quite difficult to find opportunities. So we kind of set up some webinars and a website, and that just further, pushed me to radiology, really. And yeah, that brings me to today. So the first part of the talk really is about explaining what radiology actually is. I know there's a lot of myths or common kind of preconceptions of what radiology is, and I hope that by the end of the talk, at least some of them are a bit shattered. So here are a few common myths which I've heard a lot about radiology, and I hope that over the next kind of 20 slides or so, you'll hopefully see that they're not true. So I know some of you probably are foundation doctors, so you see radiologists at a time when they're busier and perhaps not as nice on the phone. Trust me, most radiologists are quite nice. Obviously, you always get some mean ones, but it is a nice specialty to work in, and they're not exactly as you might see them when trying to get a scan organised as an F1. You don't always sit in dark rooms. That's not the case. There's a lot of variety in the job in radiology, and hopefully I'll share some of the activities that you get up to. there definitely, a lot of people say, oh, there's no patient contact, and that's not true. I think the truth is you can choose how much patient contact you want. So if you want to be like fully clinical and have lots of patient contact, you can. If you want less, you can as well. So I think you get to make that choice in radiology. So it really depends on what you like. Lots of myths about AI, and we'll briefly touch on that and why I think AI will not take over the specialty. And I'm not going to focus too much of this of the talk on it, but a lot of people talk about the radiation, and often the risks are misrepresented. So yeah, if you take nothing away from this talk, then hopefully at least this slide is like the main meat of it. But yeah, we'll go into the stuff. So what radiology is. So it's a technique-based specialty. And the reason why I say this is there's so many specialties now. There's up to 50 different specialties you can choose. And there's too much choice on what you can do. So traditionally, specialties are divided based on disease profiles, or, you treat a certain disease. But in the modern world, I think that's no longer the case. I mean, you have specialties that focus on providing care to a certain patient population. For example, say if you do pediatrics or GP for primary care, but you also have technique-based specialties. So they're entire specialties based on like a certain technique, for example, anesthetics or radiology. And often they're seen as like service specialties because they're not specifically looking after, a particular disease, but that's because the roots of the specialty are based on a technique rather than looking after a certain condition. So moving on to what radiology is today. So it's a clinical specialty that uses medical imaging to both diagnose and treat patients. And it's not just in one specific kind of section, it's all patients of all diseases. So it's quite a general specialty. And the way I like to look at it is you're essentially a general physician, but your understanding of imaging allows you to solve clinical problems. So essentially you're like a generalist who understands imaging. And there is a trend towards subspecialization, so we'll talk a bit more about that. But every radiologist has a good general base, so they can do the general stuff. So there's lots of variety in the career, and you really do have a good general base, and you're not focused on like one specific thing if you don't want to be. So yeah, here's just a few pictures from the last year, or my first year of training. And as you can see, not all of them are sitting in a dark room. So I'll just go through a few of the activities I managed to do. So on the top left here, that's myself learning ultrasound on a simulator. So there's a mannequin there in the background, and I'm just practicing like how to get the views of certain structures, and it gives you real-time feedback. So part of some of your training will be done in like a classroom style situations, so with simulators, so either with ultrasound, or I know some training schemes have like procedure simulators that you can go and practice on. So yeah, some of those schemes you get some really good training at the start on the bread and butter things. Basically, you're not just thrown into the deep end and made to swim essentially. There on the bottom left, that's me doing my first IVC filter removal. So on my first couple of weeks, you get a bit of time in everything. So I spent some time in intervention, and yeah, the consultant let me have a go, and it was really good. So to get some early hands-on exposure, that's me pressing very hard for manual compression. So I was really focusing my energy on that. But yeah, the point is you get a lot of hands-on exposure quite early, which is one of the great things about it. On the top row, that kind of purpley thing. So you get to go to a lot of conferences and learn really cool things. And what that is a portable MRI scanner. So this company bought an MRI machine to a bar at one of their networking events. And they said it's the first time in the world when you can get a beer and your head scanned in the same room, which was quite funny. So they were basically giving out free brain MRIs. So yeah, I got to experience that, which is just an alternative thing. And just next to that, I'm using some expired kit to try and practice deploying a stent. So that's just an expired biliary stent, which I'm trying to deploy. So on the bottom there, that is me doing some reporting, because that is part of the job. You do have to report. So one of the things we start on is just doing X-ray reporting. So that's me doing some A&E reporting and Googling things as well, because you do sometimes have time to do that in the job, which is nice. we don't always work. So we've got a cohort of 9 people, and we get on quite well. So on the top right there, that's us just at one of the pub socials that we went out once. And on the bottom right again, that's me practicing ultrasound biopsy skills with one of the consultants as well. And all of these are real pictures of real things that I've done over the year. So there's a lot of variety in the training scheme, and it's not just sitting in a dark room, I promise. So in terms of a typical week as a trainee, you have a mix of, say, specialty sessions. So depending on what block you're on, those will look different. But then you also have some general sessions as well. And what that means is like, general radiology, for example, a bit of ultrasound, or maybe if you have general X-ray reporting, it's not tied to a specific specialty. It's just something like that everyone does. And the exact composition of that varies depending on which program you're on. So, for example, for us, it's block structure, like everything is in blocks. So, for example, next week I'm going to move on to chest. So, like 9 out of my 10 sessions are going to be focused on chest radiology, and then 1 out of 10 is a general thing. But I know some other schemes have a different split, and so they don't do it in blocks. They might do, say, 4 general sessions and then 6 a mix of anything. So it does vary, but you'll get training on everything. So you'll meet the competencies of the whole curriculum. So it doesn't really matter where you go in that sense. And the best thing about it is you get lots and lots of consultant supervision. So when you start radiology, you don't know anything, and so the consultants will teach you. Like everything you do is checked by a consultant, and you get feedback. And even at the start, like all your X-ray reports are checked, and then you get slowly more independent at doing things. So again, most places don't just throw you in the deep end. They actually kind of teach you how to do things. You get lots of consultant supervision, and then you slowly become independent. So it's really good because you feel like you're getting taught, which is really nice, and you're not just kind of doing service provision. So here's just a screenshot of, like an example timetable. So we have teaching most mornings from 8 till 9 for work, and that's delivered by one of the subspecialty radiologists. So from the morning session, there'll be a couple of 2 or 3 sessions of reporting, like general reporting. So on chest, that'll be a mix of chest X-rays and CT scans, both inpatient and outpatient scans. We have teaching every week. So Monday afternoons are our exam-focused teaching, where we basically cover the curriculum. You might have a couple of procedure lists. So, for example, for chest, that's going to be like chest biopsies. And then, again, a bit more reporting. Hot CT is just like general inpatient CT reporting. MDT is quite an important aspect of what you do. So that's a multidisciplinary team where you have radiologists, say physicians, surgeons, all discussing patients in a room and deciding on management. And often in most of those cases, the radiologist plays an important role. So usually it's the radiologist that prepares for the MDTs and presents the cases and talks to the imaging. And then they usually play quite an active part in the management, not just from a diagnostic perspective, but if a lot of things have interventional management as well. So the radiologist really plays an important role in an MDT. So you get to spend time in MDT as well. Initially, you generally sit quietly in the back, but as you get a bit more senior, you present the cases for the radiology team, and eventually lead MDTs. So it's quite an important part of the radiologist workflow, and often at interviews you get asked about it. So it's worth attending some. I know it can be a bit boring as a student or as a foundation doctor, but just to appreciate what it is, I think it's quite good. And then duty is the other thing where probably most of you will interact. So duty is essentially taking the referrals and answering the phone. It's busy, so the phone rings every 2 minutes and you have to report during it. So that's probably why most radiologists are a bit mean or a bit blunt. It's nothing personal. It's just it's a busy shift, which unfortunately you do have to do as part of the job. So yeah, it is what it is. So typically that's kind of what a week would look like. From ST2, we have roughly 1 evening shift a week. So I'll be on call till 9 p.m. where you basically do out of hours work. So that'll be a mix of ultrasound and CT depending on what you get, basically. So in terms of a week in the life of a consultant, so very similar. The good thing is that as a consultant, you can be quite flexible on your job. So you basically just meet with the people and you decide what your interests are, and you can tailor the job plan depending on what you want. So no two consultants do the exact same rota. I think there's a mix of general work as well as subspecialty interest work as well. Now, obviously, in bigger centres with larger departments, there are more subspecialist radiologists, whereas in a DGH, most of them stay quite general and do a bit of everything. And of course, if you do interventional radiology or MSK radiology, most of your time is spent doing procedures rather than reporting. So it really depends on what you like. But if you don't want to do any procedures, that's fine. If you want to do mostly procedures, that's fine as well. You can really tailor the job to depending on what your interests are. Which brings me on to some of the pros of radiology, and I'm sure I've talked about these already, but I think variety is like the number one thing. In an era of subspecialization, I think it's one of the few specialties where you still remain very general, and you literally get to see see patients, deal with problems from all systems, which is great. And there's a real problem-solving aspect to it. So you really, you feel like you're really engaging your brain at work, which is really nice. You really think about cases and come to decisions, which is really nice. Of course, there's a new tech as well. So I know not everyone likes tech, but there's a big kind of focus on med tech. And radiology by its nature is dependent on technology and computers. So if that's something that you like, then it's a great field to go into. But I think ultimately the training is just fantastic. Like, it's very focused. You train in the activities you do are very relevant to what you do as a consultant. So you don't do that much service provision that's not relevant, and you're supervised by consultants. So you might think, 5 years, 6 years is a short training program, but the reason it's short is because it's very focused and genuinely, like, you learn every day. So it's really good. It's almost like going to med school again. In terms of the job market, it's really good. Like, there's an imaging shortfall and more scans happen every day. So the demand for radiologists is just going to increase even more. It's already high. So what that means is you won't be struggling to get a job once you finish training. Like, you're almost guaranteed a job, basically. So that's obviously very good. And in some places, they allow you to do home reporting for some of your sessions. So there's flexible working possible, or less than full time. Lots of trainees and consultants do that. So it's not like a not well trodden path. Like, there's plenty of people do that. And I put this graph in because I know if you read on Med Twitter or whatever, there's lots of people talking about burnout, and it's an important issue. But the trainees in radiology are happy. Like, generally speaking, there's a low burnout rate and a high satisfaction rate, and there's something to be said about that. And it's not worth ignoring. I think it's important to pick a good training scheme that will allow you to develop your skills, and I think radiology definitely ticks the box for that. In terms of cons, so there are obviously negatives. When you are at work, it is busy. So we mentioned that there's an increase in demand for imaging, and that's only going up. So, for example, the night registrar at my hospital will be reporting about 40 to 50 CT scans a night, which is basically no break. We're constantly reporting for the night, so it is busy. There is now, compared to if you do, say, medicine, there is a lot lower patient contact, especially early on. Again, when you tailor your subspecialty interests, that obviously can change depending on what you want to do. But for some, that can be quite frustrating at the start, because you've gone from essentially 100% clinical to then, almost going cold turkey at the start. So that can be a bit of a shock to the system to some people. As you mentioned, it's still largely a service specialty. So you tend to do things for other specialties, if that makes sense. So you don't take primary responsibility for most patients. And I guess some would say that's a pro, that's also a con, depending on kind of what you prefer. And of course, it's a steep learning curve. I mean, because it's general, you have to know a bit about everything. And so although you do get trained, you do have to study and, both through exams, but even for general life as well. And you can't blag it. Like, say if you do a scan and the consultant asks you the next day and you haven't read, that's really obvious. So you do have to do a bit of studying outside your hours as well, which is fine. But I guess it's a bit more like going back to medical school where you do have to study a little bit. And that's perhaps slightly different to some other specialties where the reliance on that is a bit less. So on to the next part of my talk. So in the interest of time, I'm not going to spend too long on it because I was going to do a whole type in the chat if you know who it is. So this is Laura Shaw, and she is the first patient to have undergone an IR procedure. So in 1964, this patient presented to the vascular surgeons, and they kept saying she needed an amputation, and she refused. And this day was the first day where radiology was used to treat a patient. So Charles Dotter was a radiologist. He was developing this dilator, and he used it on this patient to try and open up the vessels. And she had almost immediate improvement of her leg pain, and eventually her foot almost completely healed. And so this is the first case of an angioplasty, and that was done not that long ago, actually. So since then, I mean, IR's developed as a very huge subspecialty within radiology, and this is really the birth of it. So again, it's a clinical specialty that uses imaging and minimally invasive techniques to treat patients. So traditionally, it was just procedures. So you're a diagnostic radiologist, you learn how to do procedures. But now that the evidence for IR is increasing massively, the workflow is a bit more like how a surgeon would work. So you have your time doing your procedures. Most IR services now run clinics. For the small number of patients that are done as an inpatient, you'll see them on the ward. And again, not everywhere, but in some places you can admit and discharge patients, especially the elective ones as well. So for those of you who haven't heard of it, or if you're thinking about surgery, it's definitely something to consider as a career path. And really, again, I'm going to keep saying this because it's really true. The variety is just insane. I mean, both in terms of what you do. So, you basically do procedures, operate on the whole body, and you can do that in a single day, but also different types of people and personalities also enter IR. So I put this here, and it's very interesting because there's this guy called Eric Keller, who's a IR trainee in Stanford, and he talks a lot about the anthropology of specialties, and if that's something you're interested in, then I definitely check him out. He talks about the two types of personalities that enter IR, and either kind of a surgical radiologist, you're primarily a radiologist, and then you transition into IR, or you're predominantly a surgeon or you think behave like a surgeon, and you then learn imaging and transition into IR. And both of these personality types really thrive. So there's a variety of people, and again, that's another unique thing, which is quite nice. As again, a week in the life. So you'd usually spend 2 to 3 days a week in the angio room doing procedures. Have some general reporting sessions as well, maybe 1 to 2 a week, depending on where you work. And IR on call is from home, but obviously you have to come in if procedure needs to be done. And how busy this is really depends on where you are. So if you're at a really busy, like tertiary trauma transplant center, then it will be busy on call. You'll have to come in and maybe even do multiple cases on a shift. Whereas if you're at a smaller hospital, it's non-resident on call, you might not even need to come in. So it really depends on where you work. So for example, on a single day, you might have all these different things on a list. So for example, if you're doing an emergency or an inpatient list, you might do a drain for cholecystitis. You might do an embolization to stop a GI bleed. You might do an endovascular AAA repair, put in an IVC filter, which is a device put in the vena cava to stop DVTs from becoming PEs. You can treat PEs using IR, so you can put a catheter in the pulmonary artery and do a thrombolysis to get rid of the clot, or a nephrostomy, say for hydronephrosis, you can decompress the kidney. Some examples of elective procedures: so you do biopsies for a tissue diagnosis. You might do fibroid embolization, so that's blocking off the supply to fibroids and shrinking them down. Some patients have arteriovenous malformation, so you can inject medication into the malformation to sclerose it and essentially get rid of it. You might put in a port for someone to get their chemotherapy, angioplasty, as we mentioned, but also in cancer care as well. So a TACE or a Y90 procedure is developing or delivering either chemo or radiotherapy directly into the blood vessel that supplies the tumor. And you could literally do a mix of these in one day. So yeah, this is basically what you can do in IR. As you can probably tell, I'm a little bit biased because this is my interest, but it's really cool, and there's a lot of variety in the job. I won't bang on about this too much, but there's lots of patient contact. You're dual trained as an IR, so you're trained in diagnostic and interventional radiology. So you have both skill sets, which really allows you to kind of have variety in your job. The technology in medical devices is really important. It's central to IR practice, and it's a newer and expanding field, which means there's still a lot of unexplored territory. So if you say you have a particular niche that you want to develop, then you really can do that. And I think everything you do has quite high impact. Often you see the results of your actions instantly. Like, say for example, you do a bleed embolization. You can sometimes literally see the blood pressure going up on the table, and it's just a really nice, satisfying feeling. Obviously, I'm trying to be as balanced as possible and give you the full picture. And the cons of IR really depend on your perspective, I think. So if you're primarily thinking about doing radiology and you're thinking, should I do IR compared to diagnostic radiology, then the main cons are that it's longer training and it is busier work and longer hours compared to diagnostic radiology. But you also have that physical demand because, you're standing, you're operating. So those are the kind of things you think about. And I know it's not always talked about, but it's important to mention private practice as well. Generally in the UK, there's a bit more in diagnostic radiology because a lot of stuff is outsourced. So people do extra reporting as an outsource. So that's where some of the private work comes in. And that's a bit higher compared to IR. Say if you're considering surgery, then the cons are slightly different because you're thinking, right, should I do surgery or should I do radiology to do interventional? And so I think the main cons here are because of the variety, and things changing at fast pace. You often have to learn a lot and do new things, even when you're quite senior, which may be less the case say if you're like a vascular surgeon and you're towards the end of your career. I mean, you're not going to learn a new technique, whereas even in IR, as a senior IR, you might be doing new things, and that's not, not everyone wants that. Of course, there's no open procedures. It's all minimally invasive, image-guided stuff. So if open surgery is your thing, then obviously it's not going to be for you. You do have less patient ownership compared to surgery, and also if you're academically inclined, I think the field is newer and there's not as much kind of investment or development into the academic side. I mean, it is changing, but I think other specialties definitely have more research base compared to IR. I'm just going to pause quickly. I don't know if there are any questions, Frankie, or if we should just crack on.
We haven't got any questions coming through at the moment. I have asked people if they do. Just make sure if you do have any, just pop them in the chat and we can ask them. But if you just crack on for now, if that's all right.
Yeah, cool. So I just spent a couple of slides talking about the future of radiology, and I mentioned AI in this. So I think the first thing to say is imaging is going to be hugely in demand. I mean, now they're saying that there's already a 30-something% shortfall in the radiology workforce, and given the rate of increase for demand in imaging, that's just going to increase in the future. So there's going to be even more demand for radiology consultants. So there'll be an expansion in training numbers. There already is happening by the Royal College, but it's there's definitely an increase in demand for it, not just in the UK but globally as well. And of course, new technologies are always at the heart of radiology, and that's just going to continue. So there's a big thing on augmented reality. So on the left here, this is a radiologist who's put on an augmented reality headset. And so what it does is, as he's scanning and trying to do the procedure, some of the patient's images can flash up on his augmented reality headset. And you can combine different imaging methods to really help you kind of do, augment a procedure or do something that you couldn't be able to do before. So I think the technology within radiology is expanding so quickly, and it's just a really exciting time to get into it. on the right here, there's kind of more advanced imaging techniques. Of course, you probably know about X-ray, CTs, MRIs, but these are a bit more complicated. So you can do like perfusion imaging. So at the top here, this is basically eStroke, which is an AI-enabled platform that you can use to, you basically deploy this AI system on a head scan, and it tells you which bits are salvageable and which bits maybe are not. And it helps with patient selection for mechanical thrombectomy for stroke. So all of these new technologies, you know, it's not just a kind of pipe dream, it's actually being used clinically, and it's really good to see the development of the field. And down here is like molecular functional imaging. So you can basically not just image anatomy, but image physiology as well. So, you know, you can develop biomarkers and that kind of thing and assess the body's function through imaging rather than, you know, just get a still snapshot of the anatomy. So I have to mention AI. It's, you know, it's talked about a lot, and I think a lot of people say, "Oh, AI is going to replace radiologists." I think predominantly because of tweets like this. So Andrew, he basically set up the Coursera course on AI. It's a world-renowned course on machine learning, and he said, "Should radiologists be worried about their jobs because we can now diagnose pneumonia?" And so that essentially created this huge panic that radiologists are going to be out of a job. But radiologists aren't worried, if that makes sense, because I don't think AI will replace it. So every new technology, AI included, goes through a bit of a hype cycle. So at the start, everyone thinks, "Oh my God, it's going to replace everything." You then the hype kind of dies down, and there's a bit of a trough because, you know, say investors have invested so much money in this technology, and they're realizing that all the promises they're made are a bit heightened. So then there's a bit like, oh, AI again, and then you eventually reach this equilibrium, and you find a kind of middle ground where AI can help or find its niche within radiology. And this article on the right kind of highlights it. So a lot of studies at the start said, oh, AI has a higher success rate than radiologists, but in the real world, that didn't necessarily translate. Whereas this is a real world study, and it shows that radiologists who use AI but are still employed perform better than without using AI. And I think it's important because it highlights that the role of AI is going to be augmenting radiologist practice and not replacing them. So a lot of the kind of hype around AI, well, it is hype predominantly. So, you know, you're not entering a dying field if you choose to do radiology. Just like any new technology, it's just a technology that will help practice, and it won't replace kind of radiologists or the role of radiologists within healthcare. And of course, IR will continue to grow. You know, there's advances in robotics. There's kind of newer imaging things where you can have radiation-free IR. So this is a fiber optic cable that was used to do a AAA repair. So this patient was able to have a AAA repair without radiation. So it's one of the technologies that's being developed, but also new procedures and therapies. So a couple of pictures I've got here on the left here. This is an angiogram of someone's knee. And this procedure is called genicular artery embolization, and it treats pain for mild to moderate osteoarthritis. Patients who have tried conservative management, but not severe enough to have surgery. So there's currently some trials going on, and there's some decent data showing that there's pain relief for 2 years. So, you know, new procedures are coming up every day. Not every day, but, you know, quite often. And then on the right here, this is thyroid ablation. So what you can do is for benign thyroid cysts that are causing symptoms, rather than have a hemithyroidectomy, you can just do an ablation and ultrasound guidance. You know, you don't need like general anesthetic, and it's proven to be just as good as surgery. So, you know, they'll be continually developing new techniques and procedures which you get to be on the forefront of. So in terms of take-home points, I think to summarize, there is a career in radiology, whatever you like, whatever your interests are. So if you want to be really involved in patient care, you can. If you don't, that's fine. You can work on your own and sit there and report, or you can work in a team of people and, you know, you can stay general, or you can have your niche and be really good at your specialism. The training is great, lots of high satisfaction, and really the future's bright for radiology, and the job market is very good. There's lots of resources out there. You know, there's a variety of different things depending on what you like. In terms of the top ones, I think Radiology Cafe is the best one. It's very comprehensive and has lots of information about all aspects of radiology. There's a podcast called Radcast, and they talk about different topics. They have applications advice, but they also interview people about different topics within radiology. So if you're interested, then I'd definitely check them out. Pretty good. Not only Radcast, but IR Juniors also run like workshops and events about IR and applications. So that's worth checking out if that's your area of interest. I've put a bunch of like slides or people to follow on Instagram if you use that for that purpose, or some podcasts as well. But yeah, there's plenty of resources out there depending on what you like. So I definitely give some of those a follow or check them out to find out some more. Bit about careers and the application process. So the training pathway for radiology is essentially after F2, you can apply for radiology directly. You don't need to do like medical or surgical training or anything like that. You can apply directly to radiology. And it is run through training, but IR has separate selection at ST4, so you do need to reapply for that. But you still have your radiology training number, so it's not like you'll be out of the job, essentially. In the past, you needed MRCP and MRCS. Now that's not the case, although it does get you points. You don't have to have it. And most people now apply from F2, but lots of people have done, say, surgical training, medical training, something else, do then apply for radiology, and that's fine as well. Additional experience before radiology always helps, so it's not a bad thing if you've done something else, then go for it. The exams you do are called FRCR, and that's split up into various parts. So part 1 is anatomy and physics, which I did this year. The next one is basically a single best answer on radiology, and then 2B is a Viva style exam. And you basically do all of your exams by the start of ST4. So traditionally this wasn't the case, but new from this year, you can choose a preference to have an integrated IR program. So your IR training number is secured from day one, and there are 24 places for this last year. And essentially what it is your training is pretty similar, but you basically have a session a week in IR during your ST2 and 3 block, but also you have a 2 to 3 month block of IR within your core training, which most places do, but not everywhere does. And you also get a bit of time in IR clinic and MDT so that you can maintain your clinical competencies as well. ST4 is the traditional route for IR applications. And there's about 50 places a year. I don't know how many there will be split between ST1 and ST4 now that they've got this new integrated track. But in the past, before you had ST1 application, there were 56 places roughly a year for IR ST4 numbers. So the application process opens in November on Oriole, just like most other specialties. That's round 1. Some of you might look at other rounds where you can enter in, say, February. It's really for those who have already completed F2 and maybe taken an F3 or a gap year. Occasionally some places open up, but the bulk of the places are for round 1, where the application opens in November of the year before you enter. And how it works is you put your application on Oriole. You then do this exam called the multi-specialty recruitment assessment. So that's a 2-part exam where you do a single best answer on clinical medicine and an SJT as well. And that score is used to basically shortlist. Yeah. After you get shortlisted, then the top 600 get invited to interview. And then after your interview, your scores are all added up. So your portfolio score, your interview score, and your MSRA score, they're all added up to get your final score, and then you get your offers. So as we mentioned, shortlisting is based on that exam alone and nothing else. So it is important to do well in the exam, but after you meet that cutoff, then your portfolio and your interview kicks in. And this is just a kind of numerical representation on how they actually do the scoring. It is competitive. It's becoming more and more competitive, particularly in numbers. So this is a screenshot taken from the Royal College website, and as you can see, yes, the number of places does increase roughly every year, but the applications increases by a lot more than that. And although this is not official data, I heard that 2,000 or more than 2,000 people applied for the 2022 entry, like the people who are starting next week. So it is getting more and more competitive. So it's worth if you do know or are thinking about radiology early, then preparing early does obviously give you an advantage within the application.
Indra, we just had a quick question just asking which sort of areas and deaneries offer the direct IR entry spaces last year. She wanted to know if it was everywhere or if it was specific places.
Yeah, so it's not everywhere just yet because it's relatively new. I think a lot of training schemes aren't exactly sure whether they can accommodate them. I think there are about 7 places in London, and then the remainder of the places were dotted around various areas of the country. Like, I know Manchester, Liverpool, Leeds had them, and then the rest were just a few kind of deaneries. But I think they will increase because it's a college-backed initiative. So probably this year, most years will have one, but it's really up to the individual like training program director. So it's hard to say. Like sometimes they literally might make a last minute decision to offer a place. So I'm not sure about the ins and outs of every deanery, but most deaneries will have one if that's what you want to go for. But it's not if you want to do IR, you don't have to have that. Like most people still go through ST4 selection for IR, so it's not the most common way to get in. And because it's newer, it's still not sure whether it will become the more common area or common route of entry. But either way, they've maintained that both routes are fine. So it's not your only chance to get in, basically. Cool. In the interest of time, I'll try and wrap through the rest of the slides, and then we can do questions at the end, if that's all right. I don't think I've got that many left, but yeah. So this is just a screenshot of the portfolio sections. So as of last year, there were 5 sections. The first one was commitment to specialty, additional qualifications. I know there was a thing from the IMT selection that they're going to take points out for intercalated degrees. I think that's going to be most specialties, but they haven't confirmed that just yet. Audits and quality improvement is another section, teaching, and then research as well. And I think the key thing to mention with radiology compared to, say, IMT or core surgical is that there's not many degrees of separation. Like each section has 2, 1, or 0 points. So every point really does count. And when it's scaled up to 40, it really does make a difference. So you should try and get as many points as possible. And of course, the earlier you prepare, the better. But you can get so many points last minute as well. So I wouldn't worry if you made a later decision. You can still get a decent number of points and make an application. Some of you might be medical students or like towards the end of med school. So I thought I'd give a few top tips on what to do at various stages of training. Now, if you are lucky enough to get some radiology experience as a med student, it's important not to pigeonhole yourself too early, I think. I mean, the number one thing you can do in medical school is learn general medicine and get your skills up, because the best radiologists are good at clinical medicine and good at that. So the only time you get to really learn that properly is in medical school. So it's really, I wouldn't neglect all of that. It all becomes important, especially in radiology. Like even now, say I'm doing an ultrasound scan and, when I examine the patient, I'm using skills I learned in medical school. I didn't learn them in radiology. So having a good base is really important, and it really does help you. And of course, if you do well in med school, all those prizes count for points, so they will get counted. I think do keep an open mind, explore a few different specialties, radiology included, and seek out mentors, because I think they make the difference. On your placements, if you find someone who kind of takes you under their wing, it just makes a bit of a difference. So it's important to try and seek out mentors, and say if you do a project, under promise but over deliver. So say like, oh yeah, maybe I can do it, but then over deliver on what you've said, and that really impresses mentors as a general rule. In terms of stuff to do for your portfolio, if you have the opportunity to do an elective, then definitely do it. If you can do a research project, it's worth doing that early because it often takes time. Like publications can take a couple of years to materialize. So the earlier you do it, the more chance you've got for getting it in time for the application. There's like essay competitions, which you can try and win a prize. So the Society of Radiologists in Training, they run a med student essay competition that's worth entering. I'd say avoid audits because the points are specifically for postgraduate audits. I mean, it's worth doing one so you understand the process, so that makes it the next time you do it a little bit easier, but it's not going to get you any points. So I wouldn't rush to do an audit if you're still in med school. If you're a foundation doctor, I know some of you will be starting next week, so good luck to all of you. There's kind of two aspects. So on the job, there's lots of things you can do to help yourself, and then there's a portfolio side as well. So in terms of job selection, I think general jobs are the best, like say ED, Gen Med, Gen Surg, intensive care. They all give you kind of a good general understanding of medicine, and that really helps you in radiology. Of course, if you're like procedurally IR inclined, then surgical jobs, of course, help you more. And it's often better to do it in F2 because you are usually on an SHO rota, so you'll get some theatre and clinic time, and you'll have to clock patients, and you just get a little bit more autonomy compared to if you're an F1, you usually spend a higher percentage of the time on the ward, so you don't quite get some experience. And of course, it's always good to offer to discuss all the radiology requests. I mean, most people would try and get out of it if possible. So if you are brave and want to speak to the radiologist, you should, because then you get your face known in the department. So when you go down or speak to them on the phone, you can say, blah, 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 I've got all these scans. Oh, by the way, I'm also interested in radiology. Can I come stay for the case, or can I do a taste a week or something? It's always good to show interest because people remember you. So yeah, that's always a good way to get involved. Or, say your patient needs an IR procedure and it's not too bad on the ward, you can always go with them and ask to scrub for the case, because most IRs are super nice and will let you do it. So on my Gen Surg job as an F1, a patient needed a gallbladder drain, and so I went down with them, mainly because they said we need an F1 to go with them. But I asked to scrub for the case, and they let me, and I got to do most of the procedure. So that's just a nice way to kind of get some experience while you're actually at work. And then, of course, you often have to spend your free time doing portfolio stuff. Audits are important to get. So on the application, it says you need more than one per year to score max points. So you can just ask the radiology department. I mean, there's loads and loads of audits in most departments, so I'm sure they'll happily let you do some work for them. Taste a week is a must. If you can, you should do it in off-peak periods. I mean, now the new F2s are going to start, and within a few weeks, the taste a week slots are going to be really, really full, because lots of people would want a last-minute one before application. So if you can get one, say, kind of March, April, before the summer or before the application period, you're just more likely to get it on the days that you have leave. So it's not, if you can't, you can't, but it's just something to think about. And then teaching is something that you should try and get involved in. And to organize a regional or national program is something that gets you max points. So, you don't have to do something really crazy to get a regional thing. You'll have friends in other hospitals within the deanery, so you can just link up with them and organize something regional. And that's not too difficult to do. You should be able to do that. Or you can do national societies and get involved. It doesn't have to be in radiology. So do it in any specialty if you want, or if you're thinking about two specialties, then you can do your teaching thing in another specialty. It will still count for radiology, so it's not wasted effort. Alternatively, you can get a PG cert, because that also gets you points, but it is quite expensive. I know they cost between $3,000 to $5,000, so it's not an option for most people, but that option does exist if you want to do that. And of course, now it's a few months before the application opens. So if you haven't done a taster week, then make sure you do already, or do one. You might have to if you can't find one in your hospital, you might have to go elsewhere and find a different hospital. I mean, most places you'll have somewhere within a reasonable commute, even if it's not your parent hospital, another one. So, just email them if you're not having any luck in your current one. You can go on the trust website and find a contact and email until you get a reply, so you should be able to get a taster week. Of course, take part in audits, and if you want some national conferences to submit to, I think two kind of junior doctor focused ones are the SRT, so that's the Society of Radiologists in Training. They have an annual conference, usually takes place around the summer, so you can get that a couple of months before applying. There's also an IR focused one, the National IR Symposium, that's taking place in London in October. So if you have IR-related audits or projects, then do submit it for that. The deadline is meant to be the end of July, but it's probably going to be extended. So that's all on the IR Juniors website and social media. Research is hard to do last minute, but if you if your like department has some reviews, that's a nice way to do something a bit quicker and it doesn't take as long compared to say a clinical project. But it does rely on being proactive because obviously you've got a particular deadline for the research, whereas the consultant doesn't. So often it will be yourself driving it rather than your senior. Just in the interest of time, I'm going to skip this. It's a bit outside the discussion, but we did talk about the MSRA. The interview structure changes a lot, and so this is all like public information. But for the last year, it was a Teams interview. I don't know if it's going to go back in person. It's just one station with a few different sections, and a lot of it's general. So there is a starting thing talking about why radiology and the commitment. But the rest of it really is about different skills, so coping with pressure and teamwork and other skills you might have that are not specific to radiology. Although, of course, if you use radiology examples, then that gains credit. But there's a move towards things being a bit more general, so it's not like the whole interview is all about radiology. There's a few different sections as well. Cool. Yeah, that's my presentation done. I'll just leave a few minutes for question. Sorry, I talked longer than I expected to, but hopefully there's still a bit of time to answer some questions.
No, thank you so much, Indra. That was really, really interesting and informative. I mean, I learned a lot because definitely didn't know much about radiology before, and I'm sure a lot of medical students feel the same. We have got about 3 questions. The first one is, how does the competitive application to IR at ST4 work? Do you still keep your clinical radiology spot if you don't commit to IR?
Yeah, you do. So when you apply, your clinical radiology training number is guaranteed. So if you don't get into IR, they can't boot you off. You are guaranteed a place on general radiology. But IR is just a separate application because normal radiology is ST4 to ST5, whereas IR is up to ST6. So because you're extending a training and it's a new training number, you do have to reapply. But it's done locally, so basically you apply with a CV and you get interviewed by the local IR department and head of school and that kind of thing. So each deanery has a different application. So I know like some deaneries it's more competitive because it just is, and some deaneries are less competitive. Usually they take local people first, and if they don't hire enough people locally, they'll advertise it nationally to other out of deanery people. So if it's an area you want to stay in, say if you want to do IR and you're choosing between IR direct entry and somewhere you don't really want to go versus a clinical radiology number in the place of your dreams, it's better to take that because you have security and location, and it's not the last time you can apply for IR because you're committing 5-6 years of your life to this place, so you want to pick it somewhere you actually want to live because it's miserable spending 6 years somewhere you really don't want to be.
Okay. That's good to know. So we've got the audit criteria says 1 per year postgrad to get 2 out of 2 points. So if you're applying in F2, are you expected to have done 1 in F1 and 1 in F2 by time of applying in November?
No, I don't. I think it's a completed year. So you need to have done multiple in your F1 year, but not in F2. Again, they intentionally kept very vague, but if you think about it, you apply in November and you upload your stuff in December. So there's no way you can. It's very difficult to get 2 audits done in 4 months. I think that's unrealistic. So I didn't do much. Sorry, go ahead.
So you have to do 2 in F1 then?
Yeah, as it stands. Okay. Remember, all these things change, so I can't promise that this is going to be exactly the same for the year, but they don't change too much. But both audits don't have to be good quality. You can do one actually decent audit and try and get that presented somewhere, and then another just easy audit that doesn't change practice that much and just get a letter for
it. Okay. Research-wise, where are easier places to publish? Also, have you got any recommendations on conferences to attend?
Yeah, easier things to publish. So generally speaking, like radiology journals have a slightly lower impact factor than a lot of other. The academic side is less developed. So, say if you did a project in radiology and did a comparable, scientific study in another specialty, statistical likelihood again. published in radiology easier. But I don't think there are easier places to publish, because every journal will require it needs to be like reasonable quality. So it's hard to say because it really depends on the quality of the project. But if you're looking at radiology specific ones, the UK, the RCR has a journal, Clinical Radiology. They accept various things. There's no like subspecialty journals within the UK. There's some other journals like there's one called Diagnostic and Interventional Radiology, which is the radiology journal for the Turkish Society of Radiology, which is also PubMed ID. So that's another target journal. If you want to get something radiology published, just go for that, basically. There are some other journals that are smaller but not PubMed ID, so you might not get credit for it. So those will be your last ditch options, but it's better to get a PubMed ID one because some specialties say you have to include proof of the PubMed ID. So it just means it gets credit in all of the things you apply for.
And recommendations on any conferences?
Yeah, so the SRT and the like IR Juniors national ones are always good ones to go to. They have junior doctor specific ones and they're relatively cheap compared to some of the other conferences. So I know the National IR Symposium is going to be like max 20 quid, not more than that, I don't think. So that's something to go to and it's relatively affordable. Same with the SRT conference. I think the ticket price is about £50 to £60. So I think most junior that's within the budget for most junior doctors. Maybe not medical students, but I know some like bigger societies have their adult conferences with some medical student programming or junior doctor programming for free. So the European IR conference has a free program for medical students, and it's usually in like Barcelona or Lisbon. So if you get something presented and you're a medical student, then the conference is free, and often your medical school has some money you can apply for your like flights and accommodation. So that's a good conference if you're a medical student and want to go for something that's has medical student relevant programs. The BSIR, so the British Society of Interventional Radiology, they have an essay competition that's closing next week. So they have a few free registrations for a few people who are in the conference. So there's obviously the essay competition winners, but they often give free registration even if you don't win the competition to encourage medical students to enter. So that's another one, and that's taking place in Glasgow in November. Horrible weather, Glasgow in November, but it's a conference that you can go to for relatively cheap.
Okay, thank you. So we've got another one. Do you interview at every deanery you rank in your application, or just do one interview for the whole application?
No, it's just so for ST1 entry, it's one interview for everything. For ST4 and IR, because you're applying to like local deaneries, you interview on each deanery that you apply for.
Okay. And then someone has asked, have you got any sources or websites for learning how to interpret scans?
So, yeah, I think there's a few for, if you're looking for OSCE stuff, I mean, Geeky Medics is fine. You don't need advanced stuff. Radiology Cafe has some stuff as well. That's quite good. And there's also Radiology Masterclass, which has almost like structured courses on different things. So that's something that's worth doing. I personally liked Radiology Assistant. It's less structured and doesn't have as much stuff, but I found it was very good for explaining like radiology things, but also bringing in the clinical stuff. So it wasn't just purely, here's a picture, this is what it means, but it integrates things quite nicely. So if that's how you learn, then I'd definitely check out Radiology Assistant as another good one. I think those are the main ones I'd say. There's now like quite a few more, but I think stick to the main ones because they're well established for learning.
Yeah. Do you need to? We've got two more, but are you in a rush? Have you got anything to head off for?
I've got a couple of minutes, so I'll maybe answer these, but then no additional questions if that's okay.
Yeah, that's absolutely fine. So, is it worth attending interview courses, radiology courses to boost application?
It's hard to say. I think some do and some don't. if you have access to people who will give you mock interviews and you can, you have reasonably good interview skills and you read stuff on the internet, I think you'll be fine, and you probably don't need a course because there are like lots of free kind of preparation resources out there and free webinars. Say if you're struggling for time, or you're just someone who prefers having a course rather than reading, then it might be worth it. The cheapest one is probably Radcast. I'm probably not meant to promote things. I mean, I don't have shares in Radcast, by the way, but they do a good podcast, and I think generally their course has decent reviews, and it's like an online course, but they also have one-to-one sessions as well. I personally didn't go on any courses, but I've heard that if you're going to go on one, that's probably one. There's a couple of other like local ones that some departments run. I haven't heard much about them, but yeah, I think it depends on you, because some people don't need a course. You have enough general interview skills and people and mentors to give you mock interviews that a course isn't going to add anything really, because the information's out there. I think really the value is getting one-to-one feedback with a radiology consultant or trainee. So if you have access to that, then you've got to really think: is the money I put in worth it?
Yeah. And just one more quick one. So if you apply IRST1 alongside diagnostic radiology, do you get 2 interviews? How does it work?
So currently, no, you just apply for radiology, and when you rank your jobs, you can rank jobs that are just, standard radiology, or there are some options that say integrated IR and you just rank them. In the future, who knows? It's not clear yet, but as of now, no, you don't have a separate interview. There's no specific IR selection. You just apply for radiology, and if you want that job, you rank it higher.
Okay, great. Well, that was really good. Thank you for answering all those questions. Sorry that it overran a little bit. Guys, just make sure you fill in the feedback form. I've put the link in the chat, and you'll get a certificate, and just make sure you keep it. Can show your commitment to specialty later down the line. But thank you so much, Indra, and maybe have you on here again at some point.
Yeah, absolutely. And if anyone does have any questions, I think I'm trying to use like Twitter for professional things more. So cheeky, shameless plug. You can DM that, but yeah, I'm happy to give like my email if people want as well. That's fine. Frank, I'm sure if people email you, then I can get in touch with them.
Yeah. If anyone wants Indra's email, just let us know at Mind the Bleep, and we can put you in contact. But okay, thank you so much. See you guys later.
Cool. Thanks. Hope you learned something.